Welcome, I'm Andrew Gosbell. I'm the CEO of General Practice Registrars Australia. And before we get going, I'd just like to acknowledge the traditional owners of the lands on which we're joining this webinar tonight. For me, I'm on Wurundjeri land, but wherever you may be, I pay respects to elders past, present and emerging. And if there are any Indigenous GP registrars joining the webinar tonight, a particular shout out to you. I hope you get a lot out of the webinar, as do I hope all participants tonight. So just a quick rundown on what we're going to be doing. We're talking about the remote clinical exam that the RACGP runs as the fellowship hurdle. And we're going to have a presentation and then a question and answer session. You can see there's a question and answer bubble down the bottom there. I'd encourage you to, during the presentation and afterwards, to add your questions or vote for the questions that are already been posted that you would like answered as well. The session is being recorded, so if you need to duck away or you miss anything, the recording should be on GPRA's YouTube channel early next week. Just a little bit of a disclaimer, this is not a RACGP endorsed webinar. We are giving you some perspectives around the RCE from a candidate who has successfully navigated and passed RCE. So it's now my great pleasure to introduce to you Dr. Damian Hannon, who has recently passed RCE and he's on his way to fellowship, but I'll let him tell you all that story. So Damian, over to you. I'll be monitoring the question and answer during your presentation, and we'll come back at the end and we'll have a look at some of those questions and see if we can answer them for those who've been participating. So Damian, over to you.
Yeah. Hi everyone, and welcome, and thank you for giving up your Wednesday evening to listen to me. I hope that you find this useful, and I'm just going to start a presentation and get going. If I start to talk too quickly, which tends to happen when I get a little excited, please someone just pop something in the box for us to notice. Like we say, I have successfully passed the exam, so this is not an RACGP endorsed thing, but this is me trying to give you some advice based on my experience, where I went well, where I went wrong, things that I would like to have done in retrospect that might have helped me prepare and get through the whole ordeal, for want of a better word, in a slightly easier way. My background is I'm now in my final 2 days left of GP registrar training officially, before I go on to commence a Fellowship of Advanced Rural General Practice in Palliative Care starting next week. I am a very proud international medical graduate, and I'm sure there's some people here tonight who are, and I have extra sympathies for IMGs because we do tend to jump through a couple of extra hoops to work towards fellowship, and I'm mindful that the change in the exam has maybe unsettled or made you question your journey, but I advise you that if you just persist, you'll get through it just like I did. I've had a couple of hats throughout GP training to date. I've been a RLO for my training organisation, which is Eastern Victoria GP Training, member of GPRA's Advisory Council, teaching associate at Monash School of Rural Health, registrar medical educator, and I'm currently working as a future GP advisor with GPRA as well, though. And the reason that some of these things help qualify me to give this talk tonight, because I did pass, I'm soon to be a fellow, and I was a member of the first cohort to sit the RCE, so I can really give you a bit of an insider scoop as to how it really runs. There's going to be 5 main sections of this talk tonight. One will be just recovering the basics. I'm sure you're probably familiar with most of this by now, so we don't want to spend too long on that. We'll review the structure of the 4 types of cases that are in the exam. I'm going to take you through my suggestions as to how you can best prepare for this exam. We'll briefly talk about the tech and the troubleshooting issues, and then we'll open up to the live Q&A in the last 20 minutes or so of the talk. So first of all, the RCE, like all RACGP fellowship exams, is essentially assessing your competency towards to work unsupervised anywhere in Australia, subject to any restrictions with IMG status. but work unsupervised for the rest of your career. There was some talk whenever this exam was changed that maybe we should have all been let through. I personally don't agree with that. I think it's a privilege to work as a GP. It's a privilege to work in an unsupervised capacity, and the standard should be high because we have a really important job of keeping everyone safe. We're the front line of the health service, and really, if we're not doing a good job, how can we expect anyone else to? The RCE is still designed to essentially test the same skills as the previous OSCE, but what I'm going to ask you to do is forget about the OSCE particulars. My cohort wasted a lot of time trying to work out whether the cases were going to be more like the short cases or the long cases from the previous one. In essence, it didn't really matter, and the priority is that you just focus on the type of exam that you have, and that you're going to be sitting, and work towards passing that successfully. A reminder of when the exams are, which I'm sure you're painfully aware anyway, but mid-March, so and you're going to be divided into 2 streams, A and B. I sat the exam over 3 days and felt like doing the 4 cases was totally manageable, but I could have easily done 6 cases each day. So I was quite happy to see that they had changed it to 6 cases per day. My suggestion, as many of my peers' suggestion, was that those cases run back to back, as in all the cases on a Saturday and all the cases on the Sunday. Unfortunately, it looks like they've only taken half of that advice, and for, I'm sure, logistical reasons, unfortunately, the exam is now extended over an even longer period than when I sat it. But the good news is most of you will be done within a week, and only the borderline candidates will be invited to sit on the 3rd day. If you haven't already, this is the first place you need to go to start your preparation for your RCE exam. So this is in the GP learning platform run by the college. You have to enroll in this module, and it's the introduction to clinical exam for candidates. I'll draw your attention, obviously click through the course, but there's 3 tabs down the bottom. All of these resources are really excellent, particularly the tips for exam practice and the technical guide, which takes you through all of the things that you need to know about using Zoom and using certain devices, etc. If you click on the tips for RCE exam guide, you'll get a tab that comes up like this. So you click on the little burger symbol, and then what I would ask you to do is click on this here booklet, and it actually brings up this list of resources that you can download. The tips for the RCE candidates, the competency rubric, and the clinical competencies are my suggestion as to how you start to prepare for this exam, and read each of those documents clearly or thoroughly. We're going to review some of the content of those tonight, but the other 4 things that are really, really helpful, which will give you an idea of what you're going to be looking at, is if you download these 4 exam cases, which are actually written from the examiner's perspective. So it includes the STEM and the data that's presented to the registrar in the exam, as well as a mark scheme, and including the competencies. And so it gives you an idea of what the examiner is going to be looking for, and also it can kind of reassure you that even if you don't get every part of every case, there's still scope for you to maybe probably pass the whole case if you're practicing in a safe way and they get a good overall clinical impression of you. So I might actually just stop the screen briefly and just share. I'm going to share a different screen to show you that one of those cases, for example. So hopefully you can see this case. So this is one of the cases that you can download and look at. So I'm not sharing anything I'm not supposed to. And this is what you will be given access to. So it actually opens on screen as a PDF document. You will be handed remote control by your examiner through Zoom, and you'll be able to scroll up and down through the document. You can read all the details. And it usually, you get all of this sort of information on one, kind of like you would on any software, where you can see the salient details on screen, any of the best practice or medical director, whatever one you use. But then you also will then get the scenario. And it can be a bit hard flicking back and forth between them, because you're thinking, what do you want to read? Oh, I've forgotten this. And so I'm going to take you through the template that I used whenever I was in the exam, to make sure that I was getting all the salient details down. The good thing about this is it actually also gives you an example of what the questions are going to be. So questions like, what are the causes of the symptoms? How would you examine them? What investigations are you going to order and discuss your management at this consultation? You'll notice that there are also prompts included that the examiner might use to get you back on track. The other key thing to notice here is the time. The time is beside each of these. That means the examiner is actually responsible for keeping you on time. So the case is going to be 10 minutes and you will be guided through. So if you're talking and then the examiner cuts you off or tries to get you to move on, it's not because you're wrong, it's because they're trying to push you to get through the case to get as many marks as you can. And the final point on this little topic is just it actually goes through then what the competencies are, and then you can scroll right down and see the actual marking scheme for the case, and you can see that you can be adequately and fully demonstrating each of the competencies. And so you might not get it, in some area, maybe you didn't totally score all the marks in the diagnosis section, but you maybe did really well in the clinical management and therapeutic section. You may still pass because the examiner has to make an overall assessment of you based on the marking scheme. And so they will decide at that point whether or not you're at the point of fellowship, not the point of a good registrar, the point of fellowship to work unsupervised. So not or pass. And if you get this box, then you pass the station and you're moving on. All right, I'm going to share the other back to the PowerPoint now. So what is the RCE? So it's a clinical competency exam with a focus on your clinical skills. You might feel like it's not focusing on your clinical skills because we're not actually, laying hands on people. But, as a GP, I would argue that most of my work and most of my assessments are kind of done by just talking to people. You tend to know what's wrong with them, but clinical examination doesn't always add a lot, if you know the patient well anyway. There are a lot of things and a lot of documents that I think can make it quite confusing as to how you approach your study. So you'll see things like there's the core, there's the curriculum, there's the 5 domains of general practice, there's the core skills. What I would advise you to do is please just focus on the 10 clinical competencies, because that will, if you can sort of nail those 10 things, and you're seeing a good range of practice of patients anyway, you're going to be covering the curriculum regardless. So focus on the competencies. The 10 competencies are listed here. Rather than me name them all out, I'm just going to focus briefly on the ones that I think you need to pay more attention to, because I think a lot of these, particularly 1 to 5, we do this really well, really regularly. I think professionalism and general practice systems is something that we probably don't tend to engage with as much, and that's things like dealing with complaints. What's the practice policy on dealing with results? Who's supposed to be looking after each other's inboxes? How do you deal with cold chain breaches in your immunization fridge? It's that kind of stuff that we don't really deal with too much, and usually someone more senior in the practice knows. That's the kind of stuff that you maybe need to just freshen up on, because that's the level of fellowship that you need to be at. And again, just make sure you're across your advanced life support things. So, bradyarrhythmias, tachyarrhythmias, CPR, that kind of stuff, so that you're across how to manage those major critically ill patients. So going back then to that resource that I first asked you to look at, they actually then go through in the document called Tips for Candidates for the Remote Clinical Examination. They actually go through each of these domains and tell you where my cohort went wrong. And I'm not going to go through all 10 of them, but you can see tonight, you can do that in your own time, but you can see here there's a couple of key things like awkward peer-to-peer communication, and their advice is to be confident and express yourself clearly. And I would like to pay particular attention to that point, because there was a lot of criticism that this exam didn't assess your communication skills. I would argue that you showing empathy to an actor probably doesn't really show your communication skills either. I think you rationally communicating your thoughts on a patient is much more to another peer, to a colleague, actually demonstrates your communication skills almost better. That's my opinion. But if you're not doing it, and it's something we don't do because we lock ourselves in our rooms and practice on our own, it's something that we need to start doing in preparation for this exam. I'll just review some other basics. So this is a 16 case exam. Most of you will only sit 12, and you will sit those 12 cases over the 2 non-consecutive days. There's only 1 examiner per station. However, there may be a quality assurance person in Zoom with you at that time, so they might show up as a 3rd tile on screen. Their camera will be off, they will be muted, you won't see them, so just ignore them. If you have a case that has a simulated patient and a quality assurance person, then you have 4 people on Zoom, and it can feel a bit intimidating, but QA's got the camera off, and in the simulated case, I just pretended the examiner doesn't exist, because that's how you operate in that case. It's you and the patient, and the examiner is just watching. So all your communication, everything is directed towards the patient. The format does include more case-based discussion than the previous OSCE. So again, like I said, you need to get into the habit of talking. It's going to be remote, at least for this cycle, and potentially moving forward, we don't know yet. And just to remind you, all cases are 10 minutes, and you will have 5 minutes per case. And we're going to talk about how to maximize that 5 minutes best later in the talk. And again, like I said, this is all, the mark scheme is based on those 10 clinical competencies, of which there are 4 outcomes. You have either not demonstrated unsatisfactorily, adequately, or fully demonstrated a particular domain or particular clinical competency. And I just wanted to put this in as a reminder to relax, because actually nearly 85% of candidates passed this exam. So it's a really high pass rate, and that's reflective of the fact that it really is an exam that assesses what we do in general practice every day. So most of you are going to be completely fine. And if there's anyone in the audience who's watching this tonight to look for tips about, because they maybe have been unsuccessful, I'm sorry that you weren't successful the first cycle, and hopefully this will be of some use to you tonight. We talked about this already, but the overall impression is the key. So you don't have to strike gold in every single domain to pass. If the examiner thinks that you're safe and at the level of fellowship, you will get through the station. There are essentially 4 types of cases. The college has grouped them into 2 sort of big categories. The first category is with a simulated patient, and the second category is case-based discussion, of which there are 3 subtypes, and I'll go through each of them now. So remote consultation with a simulated standardized patient. This was my very first case in the exam, and I felt I probably underperformed a little bit in this station because it was the first one. And by luck of the draw, some of us will end up having to do this one first. The examiner can't communicate with you, so just ignore them is my first tip. And really, it's assessing your clinical history taking skills, or you may already be given some data that you then need to relay and communicate to the patient. You might have to counsel them on something or walk them through that. That again is something you do every day. So without even necessarily studying for it as such, you're already doing this because you are communicators. This is what we do day in, day out. So this this case, I think in my exams, I maybe that this was made up of few. I don't want to breach my confidentiality from my own exam, but this certainly didn't. This was in the minority of type of cases that I had. The next one is the case-based discussion, and this is whenever you are with the examiner. It's just the 2 of you, and you're given the STEM like I showed you, and you can scroll up and down and read the key details, and then you have to answer questions. Now, if you read here, but in this example box, it basically tells you what they're going to ask you. So you're going to ask you to formulate the problem definition. So what's wrong with him or her? List the differential diagnosis. So while you're using your 5 minutes, write down your differential diagnoses. What investigations are you going to order and why? And think about the next step, not just ordering a test, but why, and also about how you present that information. And then you might ask to take them through your diagnostic or management reasoning. And we'll go through this again in a couple of minutes. Case-based discussion with a descriptor of a physical examination or procedure. This was the one that I found the hardest, if I'm honest. And I think it's because it's something that we don't do very regularly. So quite often in general practice, we just do. We very seldom have to verbalize what we're doing to either our patients in the terms of using eponymous names for things. So I would suggest that you get in the habit of doing that over the next couple of weeks. Talk your patients through what you're doing and be sure that you have a structured approach to it. So, and this isn't a medical school OSCE where they're going to say, oh, well, I'm going to, inspect and remove the t-shirt. We're not really worried about that. If it's a shoulder problem, they want to know. So you're going to move the shoulder passively in all the movements. You're going to maybe, if you're worried about subacromial bursitis, you're going to say, oh, well, so I would do a Yoakum's test looking for impingement. I'm going to abduct the arm to see if there's any evidence of impingement, and talking like that and using terminology like that will help you. And it shows that you're already thinking of what the possible diagnoses are and that you're across your content. I can't tell you what examinations I was assessed on. However, they are really, really common ones. There are things you're doing in general practice every day. So you're not going to be asked about, you know, some complex plastics graft or whatever, you know, that some of us or some skin GPs might be doing. It's going to be something that we're all doing every day. It is not, however, you know, I'm going to listen to the 4 areas of the heart and, you know, and lie on left. It's not that kind of exam. It's why you're doing an exam and what clinical finding you're wanting to discover from it. And again, specific to the context of the case. So don't say you're going to be listening for a murmur if that's not relevant. You know, of course we're listening for murmurs, but it's about what's in the case. Okay, I'll probably talk most now about the critical appraisal one. And I think this was the one that caused most anxiety pre-exam for my cohort, because a lot of us have sort of escaped off to general practice because we don't really, well, a lot of us who are in general practice, sorry, I should say, don't really engage with research. Certainly I don't. I know lots of other GPs that do, but it's not really something I'm doing day in, day out. And so I was quite intimidated when I found out that this was going to be a case on the exam. You will be sent the official termination. The official definition is 1 or more resources to review, and that will be emailed out to you a week prior to the exam. You will only be told on the day of the exam which case to use. And the good thing about this case, the good news about all of this is that journal articles aren't beyond the level that you should be able to interpret anyway. So I was worried that I was going to be sort of really in deep trouble trying to go through really complex statistics, and actually that really wasn't the case. And the other good thing about this case is that it's actually, although there's having a discussion about the having a discussion about the research article, it's actually still attached to a case. So you still have a 5-minute reading time to review a case about a patient and a STEM. And so it's actually, even if you sort of fumble your way through that critical appraisal bit, which you won't, but even if you did, there's still a chance to pick up marks later down the line, because you're going to be talking about the case and tying it into that paper as well. So how can you best prepare for this critical appraisal section? So, well, to remind you, sorry, you guys will also be allowed an unannotated copy in the room with you. So I wasn't, but it was a bit of a stretch trying to move through all the pages on the screen on Zoom. So it's quite good that you'll be able to do that. But the way I suggest it is, what I suggest to you, sorry, is when you get your research papers, read them. Don't try to read them all in one day. Take one a day. You've got a week to do it. You are allowed to discuss it with colleagues. You are allowed to discuss it with peers, apparently. I wouldn't be speaking to other candidates about it specifically. So I think your supervisor, someone like that, is probably reasonable. Someone no other candidate would be my suggestion to you. And what I did was I wrote a summary of each of the cases, and I typed it up so that and then I just looked over it for the couple of days, and I'd highlighted all the key things and put it all in one place. And because in the exam you're going to be asked, so what's this study, or tell me what you think of this study, and so you need to be able to say things like, this is an Australian systematic review, this is a British randomized control trial, this is a study in the United States, it was a multi-center study looking at whatever. Have your strengths and weaknesses of the paper prepared already, so you can say that off the cuff. The good thing about this paper was it had the findings had a really strong negative predictive value. Talk about the p ratio, look at the relevant things and say them straight up, so that you sound really smart and you can get that part of the out of the way, and then get on to the clinical case component of that station. The phrase I used was my global feeling, and I think that just bought me time more than anything. In terms of places to go for resources about starting this, you're revising your evidence-based medicine. There's a podcast which I listen to regularly called The GP Show. One of them, it's number 39, so I think it's now about 18 months old, the podcast. It's about an hour long, and it's between the GP and another GP who does a lot of research work, and he sort of goes through an approach to evidence-based medicine. There's also a website called evidencebasedmedicine.com.au, which is specifically aimed at GPs. If you want to get into the habit of doing some critical appraisals, I would suggest that you go onto that website and you download some of the journal articles that they have. Go through it yourself. And then you can actually compare it with what the author of the website has come up in terms of their own critical appraisal, and you can see where you went right, where you went wrong. And all of those articles are, I would say, at the same sort of level and standard as the ones that I was given in the exam. This is an examiner friend of mine actually used this paper to teach herself about how to do how to read a paper, and this is available on Google Scholar free, but you can buy it for about $50 as well. And it's quite easy, light read, not too hard, and breaks things down in a nice way. So maybe a resource if you're not sure where to start. If you're not already a member of the Faculty of GPs in Training on Facebook, you should join it because it often has extra resources and exam-related comments and things go up there, and other candidates' questions might be posted on there. But tomorrow night, they're actually having a webinar on evidence-based medicine, which is being delivered by Dr. Ben Mitchell. If you go into the group tonight, you can actually download the article and do a bit of preparation, and then they're going to go through the article during the webinar tomorrow night. You can also, it's being recorded, so you can watch it later if tomorrow night doesn't suit you. Okay, so this was my approach to each station. So whenever I got into the room, you're allowed blank paper and a pen to go through the cases, and I basically had a template in my mind, then I just regurgitated onto the page as soon as I got in, and that was because I knew, well, I had sort of guessed what questions I was going to be answered, and having gone through this process, I was pretty close to the mark. And what I found was that if I had all of these things written down, so my differential diagnosis, my investigation, my management, it meant that whenever I had to answer the question on these things, I could actually focus on just communicating in a way that made me sound probably smarter than I am, but it came across structured and ordered. So I wasn't trying to think of the answer and communicate well. I only had to focus on communicating well because I'd already written the answer down, or what I thought I was going to be asked. I wrote biopsychosocial at the top because I tend to be quite good at these first two, and I kind of tend to forget the social aspects of this. So how does this affect your life? How does it affect your job? Those kinds of things. So that was just a useful banner that I put across the top. I didn't like flicking between the two pages on Zoom, on the Adobe, on the PDF, sorry. So I actually scribbled down the key points from the history. Again, you don't have to do that. I created a problem list each time. So if I was reading something like BMI 30, 31, I was thinking, all right, so do they have a fatty liver? Do they have insulin resistance? What's their lipid profile? So things that maybe weren't even relevant to the case, but in terms of an overall problem list for this patient could be relevant. Do they have obstructive sleep apnea because they're obese? That could be important as an overall health management thing. Have a box for your differential diagnoses and relay your differential diagnoses in a way that demonstrates what the most likely one is first. So don't start with the one scorpion bites and work backwards. It's going to be gallstones, so say that. Again, with investigations, try to break investigations down into small categories, because it sounds like you would in general practice. So if you have someone who comes in with flank pain, the easiest, quickest test for you to do is a bedside urinalysis. If you have microscopic hematuria or even macroscopic hematuria, then you're already going down the right lines. So whereas you can get in the moment, get a bit excited and say, oh, I think I'll organize a CT scan. Well, yes, you will, but what are you going to do first in real time that's going to help your clinical reasoning, display what you know, display your clinical reasoning? I broke it down into bedside investigations, hematological investigations, and radiological. That was my triad of things to remember. For management as well, I used an extended list, but another appropriate way to use it would be just in terms of short-term management, medium-term management, and long-term management. And if you make some points under each of those headings. And when you're really going for those extra marks, it's about being conscious that you might be dealing with someone who's presenting with COPD or whatever, but also you can say, is there, and the examiner asks you, is there anything else you'd like to do? You would say, oh well, I might encourage them to update their FOBT test if it's overdue, or an appropriate preventative health activity that makes you sound like a well-rounded GP at the level of fellowship. So I'm gonna have a quick drink and then I'll start talking about how to prepare. So there's two ways to think about this: how you prepare whilst you're at work, and how you prepare whilst you're at home. So in terms of preparation at work, you really need to start treating every every case you see as though it's an exam case. So start thinking not just about why they're there today, but all these extra lateral things, which I'm sure you're doing anyway, but just in the mindset of an exam, it's really useful to become quite polished at this. So talk your patients through what you're doing. I'm going to do this, I'm going to do this, I'm going to, you know, move, checking for this, and do stuff that you don't necessarily verbalize the things that you do, so that you're in practice of saying it. And make sure you're going the extra mile in terms of offering, you know, age-appropriate screening, talking about immunizations, and again, going that extra mile. So if you have a child in the treatment room who's coming in for their 18-month MMRV, make sure you're saying to the parents, by the way, the recommendations are that they get a second varicella vaccine. You know, it's on a private script. It is a recommendation, but it's not funded on the immunization schedule. Is that something I can offer you today? You know, that kind of stuff is the extra mile. And again, that's the stuff that pushes you definitely into that overall impression category for your exam matrix. I, in the run up to my exams, reduce my patient load to 3 an hour. So usually I see 4, sometimes 5, depending on what's happening. But yeah, I reduced it to 3, and that, and I asked for the treatment room to give me a few less interruptions in terms of walk-ins, so that I could actually just focus on preparing. And that allowed me that extra 5 minutes to kind of mentally debrief what went well and what I did well and what I didn't do well during the previous consult from an exam preparation point of view. One thing I did, and I hate doing this, but I strongly recommend you do it, is random case analysis. So you ask your supervisor, if you have a good relationship, or another GP in the practice, to basically, whoever you're close to just click on your patient list, or go back a week and just click a random patient and open your file and go through it and defend or explain why you've done what you've done in that consult, and try to do it in a timely way. It's a really good trick, but again, it's something that makes you uncomfortable, but the exam makes you uncomfortable, so you need to get used to that feeling, because it's not going to go away. The same thing can be done with just asking your supervisor to look in your inbox of results and see what kinds of things you're requesting. So, sorry, why did you request a CA 19.9 or CA 125 in this person, you know, in a 40-year-old who came in with abdominal pain? I mean, it's unlikely that they have, you know, a malignancy, but you can maybe defend it in terms of your clinical findings. Oh, well, actually, I thought they had ascites. I thought it was completely appropriate. Yeah, great. And again, as another prescribing review, so opening your file and not even focusing on the content, but just focusing on, so why you know, that you've been looking after this patient for 4 months, why are they on all these meds? Which have you initiated? Which could you rationalize? And it's a good clinical thing to do for your patients and for yourself, but it's a good study tip as well. Okay, the next way to prepare at work is to make sure you are seeing patients. So I would not recommend taking 2 weeks off preparation for your exam, but what I would recommend doing is mixing up the types of people you're seeing. So if you're only seeing people on the day, you're seeing acute medicine, which is great, but it means you're not seeing chronic disease. So that's a problem. Vice versa, if you're only seeing a certain cohort of patients, so if you're only seeing, you know, antenatal people, antenatal women or whatever, then you're not going to be seeing older people. So you need to make sure you're doing that. So you need to speak to your supervisors or your practice about mixing up your patient cohort. I suggest that you become quite vulnerable in your learning. So do things like Googling, and well, maybe not Googling, but looking up therapeutic guidelines, double checking doses, double checking things in front of the patient. Tell them what you're doing, tell them you're doing your exams. They feel reassured, and it's good revision for you. If you're still lucky enough to be engaged in teaching at your practice, I would strongly suggest that you start covering those things that I talked about earlier that we tend not to do very well or know offhand. So things like cold breaches, cold chain breaches, that's the word I was looking for. Cold chain breaches, things like complaints processes, mandatory notifications, and make sure you're across all those notifiable conditions as well. So you have to write in if you diagnose a patient with hepatitis, all that kind of stuff. Then the next category I have is how to prepare for the RCE at home. And so I would say you develop a study group. Now, study groups to me are something that I've only come across in Australia. I didn't really engage with these as a medical student. And so I've reluctantly engaged since I've been living in Australia. But my study group was just 2, which was just me and actually a fellow who'd already passed. So really it was just me and a fellow. But I would suggest the maximum number you have in your group is 4. Because after that, it's just kind of like a joint anxiety club, in my opinion. the way I would go about preparing really effectively is actually get each person who's come into your session to either run a case, and they can either write that case themselves or they can pull a case from a resource. Good places to get cases are GPRA have their clinical cases book, which has been redone in September last year to actually match the RCE format. So that's a really good place to start. I also use Susan Warren's book, not so much specifically for the cases, but just to make sure that I was across the kinds of topics that are examined. And the best gold standard thing you can do is actually split, go to the exam reports and read what has been examined before. And then if you divide it between 4 of you, there's 12 stations or whatever, or 16 stations in the exam reports. If each 4 of you write up 4 cases each, then you have, basically a run through of an exam, and you can practice all those things and go through, using the technology and talking through cases with each other in 10-minute slots, answering questions like, what is the diagnosis? What investigation? All that stuff. I suggest that you decide now where you're going to sit your exam, and that's the place that you should study. So if possible, so I had my a desk in my bedroom, and that's where I sat the exam, and that's where I studied and had all my chats, so that even just that, things that you notice, like there's a bit of a draft here, the sun can come through at this time of day. There's things that you observe about the room that you don't want to just find out on the on the day of your exam, because it can be a bit stressful. And as comfortable it is, I think it's important, if you are in a study group, that you're all quite brutally honest with each other and say, yeah, you didn't come across very confident there, because it's better to make these mistakes now than in your exam. Just to give you an idea, this was my preparation, or this was my exam setup. So you can see here the things that you need. So I felt like the table was a bit low, so I got a little table to prop my laptop on so that it was at face height. I had an alarm clock just to monitor the 10 minutes. I also had a backup watch in case this broke. Your ID, I actually sellotaped my driver's license onto a white page so that it was less fumbly to hold up in front of the camera each time. Small tip, but quite helpful to do. I also had backup ID in case they couldn't see it. I had a light, a couple of pens, and a mouse. So you need to have a mouse very specifically for this exam, because whenever you're given remote control by the examiner on Zoom to scroll up and down documents, you can only do that with a mouse. And there's it has to be a desktop or a laptop. iPads, Chromebooks, and phones and things you can't use them on this, and you're allowed to have blank paper as well, and you will be, and to take notes down, use that template or your own template, whatever works for you, and then your examiner will ask you to rip up the notes in the exam. I was very comfortable during my exam, so this is my top half looking quite professional, and my bottom half looking very, very casual in sort of gross sweatpants and Ugg boots. So yeah, it is a bit weird to sit it in your final ever exam in your bedroom, but it could be worse. You're not competing with traffic, etc., to get there. In terms of the tech, then, we're almost there before we get to questions, but in terms of the tech, you need to upskill with Zoom. You might think you're across it, but you need to be practicing it regularly. You need to be sharing screen, you need to be sharing remote control, getting in the habit of doing that. Make sure you read the technical guide and know that you're able to do everything that's required of you in terms of remote control, or how to make sure you're able to switch between your sound sources. In the mock exam that I did, one of my AirPod headphones just died. I thought they had a fine battery life. They were at 100% before, but obviously when I was using them as a dual function as for speaking and listening, the battery life halved, and therefore in the exam I ended up just using a headset like this. But again, get practice wearing a headset, because it can be a bit disconcerting to use it then if you're not used to using it on the exam day. You can feel it's a bit of pressure, it's a bit uncomfortable, so get in that habit. I would suggest you practice someone in the house just turning your Wi-Fi off, so that you can get into the habit of quickly using your phone as a hotspot to reconnect to your Zoom meeting and reconnect to your exam, because again, if you don't know how to do that now, you're definitely not going to be able to do it quickly under pressure on the day. And if you're really technically savvy, look, you can do breakout rooms to sort of practice how it's going to work on the day, but I think that's probably a stretch unless you're really, really across Zoom. You will be put into a candidate lounge. You do get to talk before the exam. Whenever I sat the exam, I was with the same 3 candidates the next day. We were all able to just chat, not about the exam, but just sort of give each other a bit of moral support, and it was quite nice. I don't know if that's going to be the case for you guys across the 2 days or not yet, but yeah, you can sit in silence. That's also a completely socially acceptable thing to do. And yes, each examiner, so you have a new examiner for each case. So it's a good thing, just if you have a bad one, just move on. It doesn't matter, just focus on the next case. The reading material, like I mentioned, will be shared on screen like I showed you guys, and you can scroll up and down, and those are the devices that you shouldn't use. My final thoughts, just to share with you before questions, are then I would suggest that you really read the case information carefully and write down those keywords. There are things that are going to point you one way than another. It might just be a phrase or a particular, and also something just you think something's weird or doesn't fit in what is out of keeping. Write it down because it's probably clinically important. Listen to the question that's being asked specifically. So they might ask you things like, what is the most important diagnosis? What is, but answer the question that's being asked. Don't go off and answer the question that you feel like you're more comfortable at answering. Bring it back to the patient like we do in general practice. Be culturally safe, be evidence-based. I would suggest you do the mock exams. My training organization ran a mock exam. I'm sure some of the other ones are as well. RACGP ran a mock exam. I know there's a cost for it, but it's definitely good experience to just get into the habit of it, and it took away some of the stress on the day. In the exam, all the examiners are people. They're different, just like I'm different from you, you're different from me. Some of my examiners were quite smiley and nice, and probably I don't think any non-verbal cues as such, but just I felt quite at ease in their presence. Other examiners I felt really uncomfortable around. Some of them were quite gruff in their communication, not unprofessional, but just not as maybe friendly as some of the others. So that can sort of throw you off a little bit. Try to just shake it off. Like I said, everyone's different, and they are supposed to be neutral. And if they interrupt you, it's because they're trying to move you on to get you on to the next question so that you can get some more points. Make sure you're using every patient you see as practice over the next couple of weeks, and use this real work as prep. Do the random case analysis, do the pathology box in, audit, all that stuff. It's really important. If you want to contact me, you can email me, which is dhannon037@gmail.com. And if you don't get that down tonight, you can always contact GPRA. I'm happy for you to share my email. And then just a bit of a note about GPRA, which I'm sure you're all a member of already because you're here tonight. But there is extra exam and learning support, employment support, advocacy, wellbeing, and hopefully some more face-to-face events when we re-enter the normal world. I think in Victoria we're still a bit nervous about being around each other. You guys in Queensland seem to be all over it. So yeah. All right, and now we're going to open to questions.
Yeah, look, thanks, Damian, and thanks everyone for your questions. Keep them coming, and if there are questions there that somebody has already asked, if you give it a like, or I think it's a like or thumbs up, we'll make sure we'll try and address them. Just while I'm going through the questions, Damian, just to sort of kick it off, having sat the exam now, and thinking back to your preparation, is there anything that you do differently now, having sat it, that you didn't do prior?
Yeah, so I'll be honest, although I prepared with a fellow, I think I prepared twice. So I only put myself in that uncomfortable position twice because I have never enjoyed that sensation. I never felt like I performed well in that scenario. And although I got through on the exam day, I think if you are nervous about this exam, the best way is to sort of meet that concern head on and actually do the practice cases, sit down and do it regularly. I probably read too much content, and I probably focused a bit on sort of stuff that I don't see that often, because I wanted to make sure I was across everything. The other thing I would advise you guys to do, however, is if you basically see antenatal medicine, that's kind of your gig, then you don't really need to revise that because you know it and it'll come back to you. I see mostly old people, and a lot, so whenever stuff about preventative care and interpretation of results and things, I was like, this is literally what I do all day every day, so I find it quite easy. So focus your study on things that you're not seeing regularly. I think that's the main thing, Andrew.
Thanks, Damian. I've got a couple of questions here about the template
Sure.
that you use. So you are allowed to have a template during the exam, but are you allowed to have that pre-prepared, and can you have it set up electronically? Are a couple of questions I've seen there.
So no, you can't. So I just hand wrote that in, but I had a mental picture of what it was going to look like. So yeah, the answer is no. You're not allowed to write anything on the piece of paper until you're in until your 5 minutes reading time have started. So it's just blank paper. But if you know those key points, then it'll be fine. And if you're doing it in practice, then it's going to be second nature by the time the actual exam comes around.
Bit of a technical one here. Headphones, are they recommended? Do you really need them, or can you just run off your laptop's audio?
Yeah, you can just run off your laptop audio. Absolutely. I think I chose to wear headphones because it was an obstruction to outside sound, as well as, so it sort of filtered the sound. So if you live on a busy road or you've lots of traffic going past, that's the kind of sound that microphones and headphones block out for the people on the receiving end, but also blocks it out for you. So, but again, it's individual preference, but you need to practice it. So if you need to practice it with friends, because some older computers, they're the sound quality is not as good. Obviously, with the newer computers, the internal speakers and microphone are sufficient. Yeah.
So it's really getting familiar with your gear beforehand and testing it out, so there's no hiccups on the day.
Mm-hmm.
Jenny's asked a question about the reading time material, the case information. Is that still accessible during the 10 minutes of the exam, or is it gone and disappeared?
No, it doesn't go and disappear. So it's on screen, and you can actually sort of toggle your screen. And this is what I mean about practicing with Zoom. You can toggle your screen to make your examiner quite small and make the information quite big, which is what I did. So I had this little P head examiner and quite big information on screen to see. So yes, it's available for you to scroll up and down during it. The problem is that some examiners use different computers, so not everyone was using it as a PDF document. So some people were using it as a sort of kind of a PDF document, but in a MacBook specific program, and it didn't come across as clearly, and the pages read 1, 2, 3, 4, which I find quite difficult. But the vast majority of examiners that I circled through had it as a PDF that I was able to easily scroll up and down. So yeah, and it's there the whole time.
Jason's asked about the SP cases. Will the examiner interrupt you to guide your time management, or you're on your own?
The examiner will interrupt you. So they'll say, the simulated patient, no, you have to manage your own time during the simulated patient one, which is why it's useful to have a clock handy.
I did see a question about clocks here. Somebody was asking about having a stopwatch or a timer if you're not good in time management, and I think that answers that question. You really need to manage your time in the simulated patient. How do you go with answering vague questions from the examiner? Asks Grace.
Well, if they tend to ask you prompts to get you back on track rather than ask vague questions. So that that wasn't my experience, that they were asking vague questions. However, I think there was a scenario in the exam whenever I was so distracted articulating all my other management of a condition so articulately that they kept saying anything else, and I was thinking, what the hell am I missing? And the key thing was that actually I would tell them to stop smoking, which I would in real life, but in the heat of the moment of the exam it completely went off my radar. So yeah, just be mindful that if they're asking you the same question repeatedly, it's probably because it's something really obvious and it'll come back to you.
Joel asks about how much detail is required for questions like, how would you examine the patient? Can you answer Phelan's test, or would you need to describe how the test is performed? You able to give us a bit of a steer on that, Damian?
Yeah, so I think it's reasonable to say you would do Phelan's or Tinnell's, or and use the eponymous name. I don't think you need to go into extreme detail because this isn't a medical school exam. This is a professional exam. You know what you would do, and if you said to me, "I'm going to do Phelan's test," I would be like, "Oh, I know what that is." But the next step would be, "I'm going to do Phelan's test to assess for a reproducible pain in keeping with carpal tunnel syndrome," or whatever it is. So yeah, it's take it rather than going through the details of describing why you're doing the test. I would advise you the details of the test or examination. I would advise you to articulate the purpose or intention behind each particular test.
Megan asked about the critical appraisals. So did you receive the papers exactly a week before the first exam? And do you know when the critical appraisal case is going to be on your, is it on the first day or the second day? Or do they specify, or is it sort of random?
So I didn't know. For me, it was on the first day, so I was told that on the first day. But from memory, but yes, so I don't think you'll find out in advance. And again, although you will be sent one or more research papers, that does not mean that you will only be asked one. I think that's probably going to be only one, but I'm not sure if you're asked to do an additional 4 cases, whether that might constitute some new papers being sent out. I don't know.
Just back to I'm sorry, I've just lost that one. It was a follow-on from a previous question and it's disappeared on me. I'm very sorry about that.
Was it Grace's question there about that question allocation? Is that?
Yeah, that was it.
So in my experience, I had one. So I'm allowed to talk about it because in the exam report is very right, as someone stated. So I had one. I think I had a couple of simulated. The majority of them were just me and an examiner having a case-based discussion, and some of those involved discussing an examination or procedure. So. Yeah, but the majority of it, you will have, I suppose, there's 2 categories of exam or 2 categories of case, really. There's simulated patient and case-based discussion. Yes, there are 3 types of case-based discussion, but if you just keep them as 2 separate categories, then the majority of the cases are going to fall into that case-based discussion category. So you should prepare more by getting used to talking and defending your clinical reasoning and what you do, rather than worrying about asking a patient, then worrying about how you interact with the patient as such, because I'm sure you're probably really good at that at this stage. As a GP trainer, you do direct observation, all that kind of stuff. But if you're worried about that component, then yes, certainly tailor a bit more time towards it. And particularly, I talk fast, I have a deep voice, I have an accent. So, these things make it harder for people and for IMGs, and English as a second language as well. So, get into the habit of talking. I used to talk to myself on Zoom, just myself in a meeting, and practice how I communicate, how I speak. I speak with my hands a lot as well. I still did that in the exam because that felt true and genuine to me. So don't stop yourself from doing things that are how you normally act, I suppose, is the other piece of advice.
I found the other one I was looking for. Jessica was asking about if you forget the name of a test, can you still describe it?
Yeah, absolutely. Yeah, so you can totally do that. If you don't know the exact name of some sort of hip test or whatever, then yeah, go for it. Absolutely, just describe what you would do. Completely fine. Because again, I can't remember the name of all the tests that I do. I kind of like ask people to roll onto their belly and grind their knee and sort of. I'm like, oh, is that which one's that? Who's Mick points or Mac whose test was that? So yeah, just yeah, absolutely, you can do that.
Mumtaz, and apologies if I've pronounced your name incorrectly there, is asking about what to prepare in that 5 minutes, and I think it's really about optimizing the 5 minutes preparation time.
Absolutely, yeah.
Here. So do you want to give us a bit of a steer there, Damian?
Yeah, so again, that's I suppose what I would suggest is you need to get the answers on paper that you think are going to be asked, or at least structure your thoughts in a way. It's about using that 5 minutes to structure your thoughts, really. If you're a person who doesn't need to write stuff down, then don't. But I personally am a person who needs to do that, so I find it helpful to do that. But think about things in terms of how you're going to relay the information as well. So, it's about, you can even use the 5 minutes to practice what you're gonna say, because you're going to be asked things like problems lists, differential diagnoses, investigations, and already think in advance. If you're thinking about organizing a scan or an expensive test or a referral, why are you doing that? Why are you seeking that opinion? I'm going to refer this patient to a cardiologist for assessment, for an opinion and management of whether they need a stress test but I mean, I would probably refer them for a stress test myself, but for a test that you can't do, because I think in good general practice we should be doing a lot of this work ourselves and not referring people too early. So verbalize what you would do in general practice and what you actually do in your clinic. And I actually relayed some of my own experiences in my exam. So when dealing with things certain scenarios, I said, well, look, I actually haven't had to experience this in general practice yet, but I imagine that if I did, this would be my approach. And you know what, to be honest, I was mostly just buying myself by talking like that, but it gave me, while I was verbalizing that, it gave me time to think further about what I was going to say. And it also, communicating like that and drawing breath for a second to speak, it gets you points because it seems like you're being quite sage and wise and thinking about what you're going to say. So that's the key thing, is take the time to jot down some key points and form your thoughts on the initial sentences that you're going to say, based on the questions you think you're going to be asked, and that's based on the exam examples that you can download online and everything I've told you tonight.
So don't panic, I think, is part of the trick.
Yeah.
We've had a couple of questions about phones in the room, more so if the internet dies and you need to hotspot. Do you know, are there any rules around that, or should that be a question to go to the college?
So it's I know the answer, but it's also covered in the RACGP RCE technical PowerPoint that you can download, and they'll be running another webinar, I'm sure, about it. But yes, you are actually advised to have an alternative source of internet available, which is in the form of your mobile phone. Your phone has to be on silent, and obviously you shouldn't look at it or touch it unless you need to access it for the purposes of hotspotting. So I had do not disturb on, and I actually had airplane mode on mine, because I thought, well, as long as my internet's working, I'm pretty quick at turning those things on. So, but again, practice cutting your internet out. Get someone else in your house to switch it off, and that you have to hotspot your phone, because if you're not familiar with doing that quickly, you're going to struggle.
You asked about accessing the case scenario and having full control during the reading time.
Yep.
It's a PDF, so you can access the full document.
Yeah. So and again, so this is why you need to practice on Zoom. So you need to go into your Zoom settings, because it's usually the same button as share screen. But there's another option if you have it set up in your settings to allow share screen and share remote control. So the examiner will do that for you. They will share remote control. So you're actually moving around a document that's on their laptop. So that they have the PDF open on their laptop, and over Zoom you're able to channel into their computer and move through their thing. So try not to close it, because that's obviously not going to be useful. But yeah, and you can scroll up and down. One of my examiners, I couldn't get the scroll button on my mouse to work on their computer. I don't know why. And one there, whenever I scrolled it, it seemed to move the opposite way. So there are a few little things that can sort of throw you. Don't get too thrown off by them. And even if the remote control function fails, so there you can just ask the examiner to move up and down as quickly or as slowly as you need.
We is asking about the physical exam stations. You covered this off a little bit in your presentation, but how do they work? If you just briefly go over some of the points you made there, because I think we're still a bit concerned about those.
So your example there is a knee examination. So you might be asked, so the examiner might say to you, so can you explain to me how you would examine this person's knee? And you might say, yeah, so I'm, given the history, I'm clinically worried that this is a presentation of osteoarthritis. I'm going to have a look at their knee, see if there's any obvious swelling that might be in keeping with an effusion secondary to OA. And then I'm going to watch them walk over to the bed, get them up, and proceed with palpation. I'm going to check. I'm not suspicious about any injuries as such, because that hasn't been given in the history. But for completeness sake, I would probably do a drawer test, assess their ACL, PCL, and then also do their collateral and lateral ligaments. I'm curious to feel about, particularly when I examine them, I'm feeling to see if the joint is hot, and that could be a presentation in keeping with gout, which, given that this man has 7 beers a night, could be a possible presentation. So talking through what you're doing, but also explaining why you're doing it, you don't need to worry worry about, I'm going to flex their knee to I didn't communicate like that. I didn't say I'm going to flex their knee to 45 degrees and do a drawer test. I said I'm going to do a drawer test to exclude an ACL or PCL injury. I'm going to do this, I'm going to do that. And that's the same for any joint or any examination you might be doing. And so I can't tell you what examination you're going to get, but it's going to be something that you are doing in general practice. So you need to be able to explain your process for doing that. So think, you know, things that are harder to verbalize tend to be the things that you do less frequently, maybe. So, I mean, I don't certainly examine, you know, you're not maybe examining someone's breast every day. So think about how you do that. You know, certainly I don't think, you know, obviously you listen to chests, well, in non-COVID times all the time, but even it might be just, you know, something about a thyroid and it's, again, it's not a medical school exam. This is the next tier up. So it's asking you for relevant clinical findings communicated in a way that demonstrates your clinical reasoning. So don't get bogged down in the minutiae. Just say, is the joint hot in keeping with gout? It could be septic arthritis. They've had a knee replacement, you know, blah, blah, blah.
So I think that then follows on to Jessica's question at the end there about, you know, you don't need to go into a lot of detail about how you position the patient, for example.
I mean, I didn't. I personally can't recall saying things like that. And even if you do, you're not going to use up too much time. So if you want to say, I'm going to get them lying at 45 degrees, fine, say it. That took 3 seconds to say. So don't not say something if it feels natural and genuine for you to say it, if you're actively restraining yourself. But if you're talking about examining someone who you're worried about, or you know, examining someone and you're talking about, I'm now moving up the hands to look for palmar erythema, and as I extend up I look for, you know, like, I personally think that that's not really particularly helpful, because in general practice we don't examine people like that. We do focused clinical examinations that are timely and appropriate based on the history and information that we have learned from our history taking or examination, or in this case, what has been given to you on the STEM. So if it feels natural, say it. It'll only take a few seconds. You'll not lose marks for it. But if you get bogged down and now they're on their left lateral side and I'm going to listen with the bell of my stethoscope, I think your examiner's going to say, yeah, move on. And if they say that, just take the hint and move on. Don't get upset that they've interrupted you.
Leanne asked a question about the webinar tomorrow night. That's an RACGP webinar, not a GPRA webinar?
No, not a GPRA one. I think I said RACGP, but maybe I didn't. All the letters are so similar. So it is an RACGP one. So you join through the Faculty of GPs in Training. It's a Facebook group. And yes, you register for the event on there. There's a link. I think it's at 7:30 tomorrow night, but it is being recorded, so you can watch it back later if you miss it. Yeah, and it's, again, good sort of, even if you don't have time to read the article, anticipation of it, I would suggest that you read the article first and then go through it properly. But if you're too busy, you've got life stuff going on, then, you know, it's something you can listen to while you're driving to work or getting the train or whatever. So yeah, just try and catch it if you can.
A quick technical one from Megan here about needing to upgrade your Zoom subscription. Do you need to do that, or can you just practice on the free version or whatever version you've got at the moment?
Yeah, so you can practice on the free version. I think meetings cut off after 40 minutes. Is that right? Don't know. So I think, but that won't matter because you're going to be invited as a guest to a professional account. I don't know enough about Zoom to know whether the share screen, share remote function is available on the basic package. So, I mean, yes, if you can do all the things that you can do on the basic package, then don't bother upgrading. I had a pro Zoom account through my other job, so I was quite fortunate that way. It might be something you think about subscribing to for the next 8 weeks and then cancelling. That's the other option. Yeah.
Yee's asking about how do you fit a lot into a little bit of time. So he's talking about management of anxiety or obesity in a 2-minute time to answer a question. Got any tips around that, Damian?
So I suppose you have to think about, you're not going to necessarily be asked, the question isn't going to be 10 minutes on how do you manage anxiety. It's going to be, so what are the possible presentations of a STEM that is maybe in keeping with anxiety? Okay, so what is your management, and make it real. So just say, I'm concerned about this patient, and I would be organising regular review. I would be asking about spousal support or family support, and maybe someone who might come with you to the next appointment. I would also be thinking about, in terms of the Australian general practice, inviting this patient back for a GP mental health care plan, which would allow a referral to a psychologist for the initial 6 sessions of psychotherapy. And I would be wanting to see this gentleman at least weekly for the next 3 to 4 weeks, and organising this some sort of safety net, talking about referrals to, that he knows about Lifeline, referrals to his own hospital triage. So it's about, and that doesn't take that long to say all of that. So it's just about having a structure to it also, that you're thinking about your pharmacological, your non-pharmacological management, your referral process, your safety nets, and make sure you get it all across quite quickly. But if you're not in the habit of doing it, it's really hard to do. And the thing is, in general practice, we're doing this every day, so we know what we're doing. It's just about articulating it and demonstrating it in a way to another GP that they think, yeah, I would let this guy examine me. I would let this guy look after my family, or this girl. That's what we're aiming for.
Quick one from Grace. She's asked if you're allowed to quote personal experiences with patients during the exam. I'm taking that.
Yeah, and I mean, look, it's only 10 minutes. It goes really quickly, so you're probably not going to have too long to say, I had this patient similar about 3 years ago. And the interesting thing with it, you're not going to say that, but you might say, I recall looking after a patient and I found in that circumstance what worked really well was doing this. And I think that this circumstance matches that quite similarly, and therefore I would probably adopt a similar, if not the identical, management plan than I did with this patient. So don't get bogged down talking about it, but certainly draw on your own experiences. I recall saying things like, I think this was in the mock, talking about tests, and I said, look, where I work, it's unlikely that I'm going to be able to access. I was like, the gold standard test is this. It's unlikely that I'm going to be able to access that where I work. So in my real practice, I would do this and this. However, I would still, if it wasn't responding to treatment, I would still then go down the gold standard line of investigation, bearing in mind that this means the patient might have to travel further. But also, that's really important, because in the case, it might say you're a GP in a rural town, or it might say you're a GP in metropolitan Melbourne or metropolitan wherever, and therefore that will change the order which maybe you would do things based on accessibility. And I think in some of them I said, look, I know, this is a metropolitan-based case, so it's likely that I can do this. In my practice, I would probably sit on this over the weekend, or I would organise whatever when. And interestingly, when I did the mock debrief with some of the examiners, some of the correct answers, they were like, yeah, I wouldn't have done that either. So, and it just shows you that no two GPs probably treat everyone the same. We all have a level of risk that we're comfortable with, and a certain realism for the context in which we work and the environment and the people that we look after. So certainly draw on your experiences, let them know who you are. You've got 10 minutes to shine, but answer the questions and make sure you get the marks.
And look, last one to finish up on there. Kendall's got headphone envy.
Oh, yeah.
There, Damian, he's wondering what brand you're using, whether you have any recommendations. So what do you think?
I couldn't tell you what these are. I got them from my employer. These are Logitech or Logitech, whatever it's called. Headphones, and they're fine. But you might not want them because they have a lead that might annoy you. Bluetooth ones are fine. Some people I was in a group with had nice big fancy Bose ones. I was a bit jealous, but whatever you buy, whatever you decide to use, you need to be practicing using it now, because you need to be aware of the battery life, what it sounds like. Does it totally distort all outside sounds so that you can't hear your children screaming at the door whenever you're trying to do your exam? And that's another thing. Just make sure you choose a really good exam location. Don't do it in a place that either makes you feel uncomfortable already, or you're going to be interrupted. So
Damian, look, with only a few weeks to go, 6 weeks or so until the RCE, just to finish up on, what's your words of advice? What would you be encouraging the exam candidates to be doing during the next 6 weeks to get ready?
Well, first tip is to start. So I only started 6 weeks out and passed, so I'm sure most of you will do the same. I think you know, particularly those of you who will get through and pass both your AKT and your KFP by the time, I know you don't find out your KFP results until much later, but you know, if you have successfully got through both of those exams, then you can be pretty sure you're probably going to get through your RCE as well. What you need to do is, after tonight, go away, create your own template, and be really honest with yourself. What scares you? What are you afraid of doing? What areas of medicine are you least comfortable with? I think you need to create your exam groups, or your study groups. You need to get really comfortable in being uncomfortable, because the exam's going to happen regardless, and if you feel less intimidated by the technology, less intimidated by the format, by the 10-minute thing, then you're gonna get through it much easier. And whenever you're in that kind of mindset, you can focus on the content of what you're saying rather than worrying about things like, oh, is Zoom gonna work? Or yeah. So go away, get your template ready, get your approach about how you plan to answer these questions ready, upskill on a bit of evidence-based medicine. And remember that this is all about Australian-based general practice. So wherever you're from, whatever you do, this is about practicing in Australia. So you need to always bring it back to the patient and the case that you're presented, and in the context of the country of which you're currently working.
Fantastic. Look, on that note, Damian, we might wrap it up. I think we've covered most of people's questions there. I'll have a quick skim through, and if there's anything missing, we'll post an answer later on. But in finishing up, if I can just give those participants who've stuck with us to the end, just a little bit of a heads up that GPRA's Clinical Cases Volume 2, the second volume of clinical cases, we've just received it from the printers, so it'll be available from the GPRA shop by the end of the week. So look out on our e-newsletter on Friday, because all the details will be there if you're wanting to get some more cases to practice on. So that's a bit of a hot tip for those who are still online with us now. But look, Damian, thank you so much. There's been a lot of comments in the Q&A thanking you for your sharing your experiences and your advice and your tips with everyone. So for those who are still online, very best wishes for the upcoming RCE. I hope you go really well. And for Damian, thank you so much for your time tonight in sharing with everyone.
Thank you. And good luck for everyone for their AKT results tomorrow as well. Fingers crossed.
Thanks, everyone. We'll wish you good night now. Bye now.